Thanks, Amin. I'm going to, I think, probably ditch the talk I was going to give because, in the interest of time, given that it's on my watch, it's 2:30, which is when I was supposed to stop talking. So I think we can catch up a little bit of time, because what I want to pose to you is some questions. The previous speakers, I think, have produced some fantastic data, and they've drawn out what I think are some of the key issues. One is the sort of issue of evidence-based care, which Cody talked about, evidence-based medicine. We've talked about inequities in the system. We know this is going to be one of the major challenges. And we've talked, and speakers have talked about the costs of healthcare. And to me, that's one of the, I don't know whether you know of the term elephant in the room. It's the sort of the big thing that people never ever talk about because it's just too big. And that's really, how the hell are we going to pay for healthcare in 2020? So I'm going to just very quickly flick through some of these slides. I mean, some of the changes in care, obviously the sort of biologics and the costs of those we've talked about. We've talked about consumer simulation, personalised care, and we'll finish off this session with patient involvement, because that's really, I think, what it's all about. Now, if we look at the changes in the ways in which we can now deliver care, and very often we're not actually doing this, but one of the things is the use of this little device, if I can find it. I hope it doesn't go off when I take it out of its pouch, but the iPhone. You know, how much of our consulting could actually be done over this? And remember, the way that technology is going, within 5, 10 years, even now in some situations, we can view the patient. There is a device now for ultrasonography on this. A cardiologist in England has produced an iPhone application where you put it on your chest and you take it off. After you hold it there for a minute, you take it off and it prints out for you the last 15 seconds of the ECG, and if you've got the special super duper device, it'll give you the phonocardiogram as well. So, you know, life is going to be different. If you think about the ways that you interact with patients now, and we know that, 60-70% of diagnosis can be made on a history alone. Certainly when you're dealing with chronic disease in patients that you know reasonably well, how much of it could be done on this, rather than having the patient travel for 2 hours to see you, travel home for 2 hours, and spend 30 minutes in the waiting room, if you're lucky, if he or she is lucky, and then 15 minutes with you. So, I mean, we've got to think about these things, because this is going to change the workforce absolutely incredibly. In terms of the issue of prevention, we really do have to look at this, because if you look at workforce training, if you look at workforce predictions, and we're starting to do this now in Australia, but I know that if you look at workforce predictions from anywhere in the world, they're usually predicated on the model of care at the moment. So we say, how many doctors do we need in 2020? How many nurses do we need in 2020? But it's actually predicated on the way that we work now. And yet we all know, if we think about it, we're not going to be delivering care in 2020 the way we do it now. So I think it's much more important to say, what are we going to be delivering? What are we going to be delivering in terms of healthcare in 2020? Who are we going to be delivering to? And remember, and Cody showed these extraordinarily well, those figures of the ageing population. You know, with a very significant amount of the population being over the age of 65. They are not necessarily, I think an increasing number of those 65-year-old pluses are going to be living independently, but there will become a time when increasing numbers of those patients are going to be in some sort of care support facility. The other thing, of course, that's going to do when you're thinking about economics is that you are going to have a much smaller percentage of the population that are working and are paying taxes. Now, there's only one thing that's certain in this life, well, the two things certain, one's taxes and the other's death. I can tell you that one of the things that happens in our country, and I think it probably happens around the world, and that in many countries, superannuation, your pension is tax-free. I can guarantee you that that will not continue because most of us, the only earners in the world will be those who are collecting superannuation. So governments will have to tax it somehow or other. But it will put very significant constraints on budgets of countries and how they're going to actually fund this. We all know about the burden of disease that we're going to have to face with the ageing population, and I won't go into that. In terms of the context of workforce, we need to look at local needs, we need to look at national needs, and people have already said that this is a global issue. I don't know how many of you are aware that in this decade alone, that's 2006 to 2016, we are 4.5 million health workers short around the globe. So we've got a big catch-up to do. And when you think about the services that we need to deliver to the ageing and chronically diseased population, that's going to pose a real challenge to us. In Australia, and I think we'll find this in most countries in the world, the health workforce is one of the largest segments of the employment industry. It's an increasingly feminised industry because it's driven very much by nurses. It's the fastest growing area of most employments in most countries. And if you look at the economics, healthcare is predicted to cost about 20-25% of GDP by 2025. This was Robert Fogel, Nobel Prize winner in economics in, I think, 1996. America will be doubling its healthcare expenditure by 2016 to about over $4 trillion. The total health spend this year around the globe will be $7 trillion. And we in Australia will be we're spending about $100 billion, and that'll double by 2018. So, and when you think about the fact that health is very much a human resource intensive industry, a lot of that spending will be on new people. So what are the options for meeting increased health, the increased health demand? And remember, this is not just about aged care and chronic disease. It's about the fact that humankind has this insatiable desire for health, and probably it wouldn't matter if we spent 50% of GDP on health, there'd still be some people who felt they weren't getting what they thought they needed. And so that's going to be a real problem, and we see this more and more now, that it's young people who are demanding that things are done. And that's why this sort of shift from the youth culture to the health culture, getting people to take responsibility for their own care, is going to be really important as we go forward. It is, I think, about extending the role and the working life of current workers. You know, we used to talk about retiring at 60 or 65. Most people don't want to do that. They don't necessarily want to work full time, but certainly we know that one of the best things of staving off the advent of Alzheimer's disease is to keep yourself active, both mentally and physically. So continuing to do something, I think, would be very useful. Somebody mentioned, I think, Cody, it was you, the issue of mentorship. Well, you know, here's a proposal. I think there are a lot of young surgeons, young physicians, who perhaps don't have the clinical experiences that we've had, who would very much welcome an ageing physician or an ageing surgeon who perhaps doesn't want to operate, but has an enormous wealth of clinical experience, being their mentor over the iPhone, doing it from the comfort of their own home. I have a geriatric, he's not really geriatric, he's actually a professor of geriatrics. He's about my age, so he's certainly not geriatric. But he has actually run a geriatric service at a hospital 150 kilometres away from his office in Brisbane for the last 3 years, and the patients love it. His aim in life is to actually continue to do that till he's 90 and probably do it from the comforts of his own bed. We have to, I think, look at creating new types of workers. It's about physician assistants, nurse practitioners, carers, health coaches, all of these sort of things. People who know a little bit about the health system and can help guide patients through the system, so they know exactly what they can get, what's going to be helpful to them, and they're actually doing it. They're attending their appointments when they need to. They're taking their tablets. All of those sorts of things. We've talked about the improving the efficiency of the health system. Most health systems, and we had a wonderful study in Australia some 5 years ago now called the Productivity Commission at Australia's Health Workforce, and I suspect it's no different in most other big health systems, suggesting it's 20% inefficient. Most systems, most big systems where you're spending 10% of GDP are going to be inefficient purely and simply because they're that big. It's less inefficient, I think, in the private sector, which is saying something. But we need to look at those efficiencies. How much of medicine, for example, is practiced in hospital is still requires doctors, nurses filling in forms. Patients coming into hospital and still having their history taken 4 or 5 times, or even more than that, as they travel through the hospital from the accident and emergency department through to A&E. This is a waste of time. And still there are challenges, as you know, in terms of getting electronic health records. Most countries have spent billions of pounds, dollars, krona, or whatever. But there are very few systems around the world that have really good electronic health records, and yet we actually don't worry about having our banking record on a little card that we put in a hole in the wall somewhere, hoping that somebody's not on the other side. So I think the issues of the way that we improve efficiency by using technology, by using telehealth, e-health, are really going to be very important. And I think the issue of prevention, whether we use moving from an health paradigm to a health paradigm, are very important. And that's going to require some really innovative ways of improving health literacy. And that feeds into some of the sorts of things that people have talked about in terms of inequity. So the models of care, we've talked about physician assistants, which are in the United States, I think very successfully, but now being adopted by some other jurisdictions. We've actually just started the first PA program in Australia. Other middle level providers, nurse practitioners, carers, who I think could be utilised much better than they are, and all sorts of assistants. And moving a little bit, picking up the issue again of generalism versus specialism, I've got a feeling we may be going a little bit too far down the specialist route in many countries, and we need to pull back a little bit, I think, and understand that certainly in terms of treating chronic disease, whether it's a generalist physiotherapist or a generalist allied health professional or a general surgeon or a general physician, these are probably the people that we need to make sure that we're training. We are going to be looking at a population that's much more connected, both the health professional population and the population that we're treated, in a far different way than we are. And I think we need to be looking at where we train these people. Hopefully this will come up in discussions in a few minutes about training. But this is the last slide I'm going to show, and it really shows the sort of health workforce lifespan. This is a study that we've been doing recently, just sort of mapping the health system in Australia, or the health workforce in Australia. But we've got to think sensibly, carefully about how we recruit people into the health system. And remember that the retired bit is going to go out to when you're about 90. Certainly there are people here who can be very, very effective in the health workforce well into their 70s and into their 80s. It's about role delineation. What are we going to accept that people do? And there are many things that happen in healthcare, for example, that you can't do because of some rule that says it's only a doctor who can prescribe. Well, why can't pharmacists prescribe? And they can in some situations. Some countries allow pharmacists to prescribe, or physiotherapists to prescribe certain drugs. Should we be a little bit more flexible in this sort of thing? They're the sort of questions that I think we need to ask. because I think that will help in terms of expanding role delineation. It'll help in terms of how we recruit people